This is the CT scan in the parasagittal section showing on right side the presence of opacity in the already dissected ethmoidal cavity. This is a patient with nasal polyps post primary sinus surgery. What we can note is a large Onodi cell which is compressing the sphenoid sinus. The Onodi is opacified, whereas the sphenoid sinus looks to be quite clear. This is the right side, and on the left side, though the Onodi cell is present, since it is bilaterally symmetrical, it is not diseased. This is the normal side, and we can see how complete septations are there, including the coronal scans. So this is a patient who was been previously operated 2 years prior, has presented again with nasal obstruction, severe symptoms, and this is the endoscopy after a thorough preparation post 7 days of antibiotics and steroids. What we now see is a rather nicely clear opening, a large enterostomy, some thickened soft tissue over the posterior wall of antrum, and synecdoche, as well as a very large polypoidal and hypertrophic middle turbinate. We'll start over with using a coagulation wand to remove the synecdoche, ablate it. We take care not to use the face of the coagulation wand towards the septum too much, though it does cause a slight trauma, but mostly the edge of the wand, the face of the wand, faces the lateral wall, and we do ablate some tissue so as to create some space between the anterior septum and the lateral nasal wall. Once the synecdoche has been removed, the coagulation has an advantage to also cause hemostasis and not soak the endoscope camera. This is followed by reduction of the middle turbinate to see if we can manage with just reduction of the middle turbinate, or do we need to proceed with a formal partial turbinectomy. We can see that it is all inflamed mucosa. A shaver blade rather quickly improves our overall access into the middle meatus, which was previously impossible. A point to note is that in case you intend to preserve the middle turbinate or even excise it, one mustn't really do this step very high up towards the axilla, because that can make the middle turbinate floppy and later on lateralized, thus occluding your frontal recess. We have gained some space by debriding the lateral aspect of the middle turbinate. However, still, since we are to access the sphenoid, small sphenoid and the Onodi cells, we take the call to remove the middle turbinate partially, at least the inferior third or half of the middle turbinate, while preserving the superior half at least. Once again, a caution to not go too superiorly to avoid having a floppy middle turbinate that can create troubles in the frontal sinus drainage pathway. Any straight scissors or a straight sharp through cut is adequate for this step. One must not use too much Blacksley hair or torse the middle turbinate, because that ensures that it does become floppy. So sharp instrumentation avoids any undue force, rotational force on the middle turbinate. What we can appreciate is the ethmoids are rather well dissected in the prior surgery, and though our CT showed us that there was opacification, all that seems to have gone post the steroid use. So if we can summarize the issues in this surgery, what has led to revision is basically just a severely hypertrophic and edematous middle turbinate and an Onodi cell. Now we can see that we are trying to identify the sphenoid os, and since we do not want to puncture the Onodi cell just as yet, we want to identify it as low as possible. Already the sphenoid sinus is small as compared to the Onodi cell, which is rather big. So we take our shaver blade, we follow the choanal arch, and we gently puncture it without using undue force to give us an entry into the sphenoid os. We can see that we have found the sphenoid os. While maneuvering the sphenoid sinus, it must be borne into mind that the blade of the shaver must always be under vision. No blind use of microdebrider blade inside the sphenoid sinus cavity is ever recommended. Achieving good hemostasis prior to proceeding further is very important. Here we are using the same coagulation wand to achieve hemostasis at our entry point into the sphenoid os. So our surgical field remains clear and we remain oriented. Again, just trying to achieve some more hemostasis on the resected ends of the middle turbinate and the bare mucosa. The coagulator works only on the mucosa and not on the bone, so there's no purpose using it on the bone. Once we have achieved the hemostasis broadly, we get back to our sphenoid os. You can see the choanal arch here. The sphenoid os has been entered, but as of now we cannot identify anything about the onodi or the septations. So this still needs to be enlarged safely before we can do any instrumentation or dissection inside the sphenoid cavity. In the presence of onodi, it is strongly recommended that any entry point into the sphenoid, any dissection in the sphenoid must be done post adequate widening. Here we use a Hedgek-Koffler punch to enlarge the sphenoid os. This is normally done inferiorly as well as inferiorly and laterally. We avoid going superiorly. Inferiorly, one must be careful of the septal branch of the sphenopalatine artery. One can use a septal elevator to gently push the mucosa down to get the artery out of field and to avoid unnecessary bleeding. Here we are enlarging the os slightly more towards the septum and inferiorly where it is quite safe. One can use an downward biting punch or an upward biting punch upside down. Both work equally well for this step. Irrigation with warm saline or Ringer's lactate at body temperature helps in achieving a good field, good surgical field and hemostasis. Now one can note now probably just the vision of an edge of the onodi cell septation. Inferiorly is the sphenoid, as we can see here, and superiorly is the onodi. We'll be clearing some more mucosa. So while now one can appreciate very easily the sphenoid os and the straight septation that separates the onodi above with the sphenoid, we can see already the landmarks for the optic nerve and the optico-carotid recess in the onodi rather than the sphenoid in this case. Though this much opening looks adequate and courtesy the steroid use, the onodi seems to be clear now. And the polyps seem to have regressed, but the goal of a surgery is to remove all septations for the patient to use ample amount of irrigation to prevent further recurrences. Since that function was achieved well in the previous surgery on the anterior ethmoids, the same has to be done for the posterior ethmoid and the onodi, and this opening needs to be enlarged further. We can see a ledge of bone here which separates the onodi from the rest of the posterior ethmoidal and the anterior ethmoidal cavity. We seem to be pushing this mucosa on the anterior face of sphenoid slightly down to put our septal branch of sphenopalatine further lower to remove some more bone. We use the same bone punch to remove some more bone. Most of the openings we make during surgery we'll have around a 40 to 50% reduction in the amount of opening we do after 6 months, and that has to be borne in mind when we create an opening. And since it's a revision surgery, that must be also put into consideration, that we do not want further revisions. So making a large opening into the concerned sinuses, which allow a sufficient amount of fluid for irrigation, is the most important goal of surgery. The same bone punch is used superolaterally to remove the party bone between the onodi as well as the rest of ethmoid cavity. The Hackett-Koffler bone punch is a wonderful instrument for all this work, because one can clearly palpate the bone which has to be dissected and remove it in a backward manner. So we are trying to remove some more bone inferiorly to obtain a straight trajectory of instrumentation when we go on to remove this near complete septation between the onodi and the sphenoid. One should probably also take notice that we do not want to reinvent the wheel. The part of the surgery, prior surgery, which has been rather done well, we do not want to be doing anything there. The mucosa already has healed. There seems to be no justification in trying to do anything more to the mucosa there. The goal of surgery was just to create a straight field for the saline solution for further irrigation, and that has been done partially through a partial middle turbinectomy, and the rest of it is being done now with removing this excessive soft tissue that lies in front of the sphenoid sinus, as well as the onodi and the bone that separates the onodi from the ethmoidal cavity. Once getting rid of the excess mucosa, we can see some more bone, which we'll be taking off. So we'll be using the coagulator again to achieve some hemostasis onto the raw mucosa that we have created with the microdebrider. At the same time, we can use this on the ablative mode to reduce this hypertrophied soft tissue onto the posterior inferior wall of the enterostomy, the erstwhile enterostomy, to create some more nasal patency. While using the coagulator, one must also be mindful of which mode we are using the coagulation on, whether it is ablative or whether it is coagulation. Once we have reduced that soft tissue, we can see it's a far better field for us, and the sphenoid has been opened rather widely, showcasing the septation between the onodi. The rest of septations are now being taken off, and now this looks into a complete ethmoidal cavity. While doing resection of the cells in the ethmoid and sphenoid, wherever possible, it is wise to not create circumferential mucosal trauma because that leads to more scarring. If one or two mucosal surfaces can be left untouched and unscarred without making them raw, it's always advisable in long term. Here we are trying to use a Heberhold cranial through cut to resect the Onodi septations. Since most of these septations will attach to either the sella or the carotid, they are never to be avulsed. They can either be drilled or they can be cut through with good through cuts. In this case, through cranial through cuts, which we reserve for these steps. Here we are using a slightly bent through cut in an upside down manner to remove some more septations medially. You can what you might also appreciate is that until unless we would have taken down this amount of sphenoid wall, entering into this cavity and dissecting would not be possible. While merely visualizing with the straight or angle endoscope is possible, instrumentation and dissection inside the cavity requires a much larger space. We again use the cranial through cut to take down some more septations. So as the septations become angled towards a certain region, it becomes difficult with the straight instrument to remove all of them. And removing all of them may not be really required beyond a certain point. The only goal is that to join both the sinus cavities, the sphenoid and the onodi, for the sake of irrigation. So once again we use a angled through cut in an upside down manner. So sharp and good quality through cutting instruments are the most fundamental part of any sinus surgery. One must have them in all form of size and shapes. It could be a straight, it could be a 45-degree turn, it could be in different sizes, as the bite size could vary depending on what applications you intend them for. Now one can see that with a slight angulation we are able to achieve nearly a complete takedown of the septations and convert both the sinus cavities into one, akin to probably how we manage a mastoid cavity as well. So just because our angulation was still limited, we are trying to see if some more bone removal can give us a little bit more instrument leeway inside the sphenoid. As far as possible, unless until it's a transcellular approach, we try to avoid the drill because it does induce a lot of fibrosis and scarring. So we use bone punches and through cuts a lot in routine sinus surgeries and resort to drill only if the approach is towards a transcellular one. We are probabprobably reaching the bottom limit of our dissection. Any inferior, we will have to probably remove this septal flap or go through the septal artery, which would be unwise. Wherever possible, maintaining integrity of the septal vasculature is a good thing. One must try to preserve. There seems to be no rationale in unnecessarily sacrificing the septal artery. So now one can see that for most part our access is nearly done. We can irrigate the entire sinus cavity in one go. Here we are using a curved suction to simultaneously clear the nasopharynx and the sphenoid and joint ethmoid cavity. The whole skull base can now be visualized from here. One can see the optico-carotid recess, the optic nerve prominence, the intersphenoid septum clearly in this cavity. Post-irrigation, one can see how well the mucosa is preserved. One must keep it that ways. There seems to be no reason to scar this mucosa inside the sphenoid beyond what we have already resected. We can see the start of a pterygoid recess inferiorly, which goes laterally. It's a reasonably well pneumatized sphenoid laterally. The curved suction is going towards the pterygoid recess. In the end, we can even gently mop our cavity with a saline-soaked mucosal patty, just to be 100% sure that we are not leaving any septations or any lesion behind. This kind of cavity now is, I believe, reasonably well amenable to be irrigated thoroughly with either a saline or a steroid infused saline solution on a regular basis. The goal being to avoid oral steroids frequently and to shift to the topical version. Once your goals of revision sinus surgery have been accomplished, so to say, that when all septations have been removed, one can comfortably say or realize that the surgical part of the patient's treatment is over, and probably any severe inflammation or recurrent polyposis in such a wide and clearly open ethmoid, sphenoid, and maxillary cavity could only in future need, if required, maybe steroids. And if we are reaching the cap of the steroids, we could put such patients, consider them for biological drugs as well. But before we put patients on biological drugs on a fair assessment, it must be borne in mind that the surgical part should be over. No septations must remain in the ethmoid cavity. We must have a wide enterostomy. The frontal sinus must be patent and draining. No Onodi, Haller, or any other cells must be there. And once that has been achieved, we could probably reaffirm to our patients that the part of surgery is sort of over, and we would be looking to medically manage these patients for a long time. Now we're using a 70-degree endoscope just for a final view. We can rotate it any which ways in the maxillary sinus. It seems to be clear. This is the pterygoid recess of the sphenoid, also looks to be clear. Seems to be no unreasonable mucosa or granulation tissue here, no fungal elements. The ethmoid cavity and the frontal recess also looks to be clear. Very small, tiny osteoma seems to be there in the region of frontal recess. We can leave it behind without any trouble. The resected middle turbinate seems to be okay. No active bleeding, and this normally completes our procedure.